Good morning. This is Babak, Larian, for another parathyroid Q&A session. I'm very happy to be here and hopefully help answer some questions and clarify some of the mysteries of this unusual disease. In any case, I'm going to go ahead and start by answering the first question that comes from Lisa. Lisa Gonzalez. So, good morning, dear sir. My question is regarding a half parathyroid which was removed and frozen at a major hospital. First of all, the half parathyroid is diseased according to the surgeon. I've been labeled hypoparathyroid, but what is the science behind the hope that the half diseased parathyroid will secrete? Well, if you have all diseased glands and the remaining gland which was preserved is half a parathyroid, then presumably you had a subtotal parathyroidectomy. So let me spin this around, okay? So as you know, hyperparathyroidism comes in many forms. And one of those forms is symmetric hyperplasia. Usually symmetric hyperplasia happens either in genetic forms of hyperparathyroidism, but usually more often in people who have hyperparathyroidism causing hyperplasia secondary to kidney disease. And so, because the kidneys are missing, there's no vitamin D to suppress the parathyroids grow and try to produce more parathyroid hormone, which in effect causes more elevation of calcium, more calcium coming out of the bones, and so on, and they grow. But the people who don't have kidney disease most often present with what we call asymmetric hyperplasia, which is each gland being a different size. And you can see that in this depiction that I found in an article, where this patient had 4-gland hyperplasia, but each gland is of different size and shape. And when they looked at them under the microscope, they were all abnormal, densely populated, some more dense with cells, some less, but still abnormal, right? In any case, the way to treat hyperplasia is either do a 4-gland parathyroidectomy and then auto-transplant half of one into a muscle, take out 3.5 glands, or take out 3 glands. And the choice between these two is dependent on the last gland. So if the last gland is small like this, you may choose to leave the entire last gland because the growth rate of this gland is lower than these, right? If the gland is bigger, maybe twice the size of this, then you can cut it in half and leave it in place, right? I'm assuming what your doctor did, Lisa, is either left half a gland in place like this and removed the other 3.5 glands and put the remaining half of that gland into, froze it, cryopreservation, right? Just in case you have low functioning. Now, the idea of curing someone who has parathyroid hyperplasia is not a reality, right? What you're essentially doing is you're removing the abnormal glands, all 4 are abnormal, but trying to keep the gland that's smallest, right? And the gland that is smallest is the one that probably has the slowest growth rate. So this one is growing much faster than that one, right? So if you keep this one genetically has a slower growth rate. And in doing so, in keeping this one, you are probably going to buy a lot more time before this one grows larger and larger and larger and starts to produce more hormone, right? So you're essentially buying time. Now, for someone who has a very slow growth rate, they may not need another surgery in their lifetime, right? And they may be essentially cured, but have a diseased gland that just is not diseased enough to overfunction, right? And so it is a guesstimation that when we look at these 4 glands, we take these 3 out, we're guessing that this one has a slower growth rate because it's smaller than that. And most of the time, that's a correct assumption, right? But we have no choice. we're not left with 3 glands that are abnormal and 1 gland that's normal to use that. We're left with 4 abnormal glands, and we're trying to make an estimation of which one to leave behind to buy the most amount of time before that gland gets large enough to produce enough hormones to disturb your system. So yes, in your particular case, Lisa, you had half a gland left behind, either transplanted, auto-transplanted into a muscle, or left in place, and another half preserved, right? Just in case the half a gland that was maintained in your body didn't work, they could at some point go and take this frozen abnormal gland, right, and reimplant it in a muscle in the hopes that it would start to work. That's the only option left. They don't have any other gland available. Now, there's a lot of controversy about cryopreservation, if it works or not. So half the places that do it swear by it and publish articles that it works, and half the places that do it say it's not consistent, it doesn't work, and so on. So, there's a lot of technical issue. There's also a lot of problems with the gland functionality. With cryopreservation, it's not a perfect science, right? But you do have the option of getting that gland and putting it back in the hopes that it'll start working. Yes, it's not a normal gland, it's an over-functional gland, right? But when it's smaller, the functionality is less. When it gets bigger, the functionality will be more. And if they reimplant it and hopefully it works, you may have a lifetime where it doesn't get to be large enough to be problematic, or in 10 years, 5 years, whatever number of years, it may grow large enough to start overworking, in which case they have to go back in and remove that out of the muscle they've implanted it in. And that's the only option left, essentially. When you have hyperplasia, you have only abnormal glands to work with, right? And you hope to try to control the problem, but all right. Now, you also ask, is the fact that my proinsulin level coming up 3 times the normal a factor, hindrance, or a red flag? Well, there's no clear connection between the insulin-producing cells of the pancreas and parathyroid or functional issues. Not that I know of. So I don't think there is a connection, a direct connection. It's probably an independent thing. A proinsulin is the pre-insulin form. So first the body makes pre-proinsulin, then it turns into proinsulin, and then that turns into insulin, right? And these changes occur in the pancreas itself. And if your insulin levels are higher, probably it's indicative of a functionality issue of the pancreas, or the fact that your body's needs are increasing. If you have weight increase and your body needs more insulin to manage the sugar and manage all the things. I'm not an expert in this area, but I don't think there's a connection with hyperparathyroidism, my dear. Best of luck. Michael Melvin. Good morning, Dr. Larian. Thank you for this session. My pleasure, Michael. I'm a 20-year-old man with a calcium that has been stable at 10.7, so elevated, for the past year. Vitamin D 60 in the normal range, and PTH hovering around 50. 15 to 65 is in the normal range, so 50 is in the upper side of normal. My question is it possible that I have had hyperparathyroidism for potentially years that has been lingering below the normal threshold that has been missed? Yes, absolutely. Hyperparathyroidism doesn't develop overnight, okay? Let me explain. So, let's see. So, hyperparathyroidism develops because a mutation occurs in the sensor for calcium on the surface of the parathyroid cell. So that one cell that has the mutation now has a higher setting for calcium, 11, while the normals have a lower setting, 9. And as the functionality increases, the calcium level goes up and the normal cells stop working, while the abnormal cell doesn't realize it's making a mistake. It wants to go to a number 11, right? And it slowly divides and gets bigger and bigger and bigger. And this is a slow process that takes years, right? For this thing to get bigger and bigger, to get large enough to produce enough to be able to maintain a calcium of 11.0. So, you know, if you had multiple calcium levels, you would notice that over time, maybe your calcium started around 9.2, 9.3, right? And then it starts going to 9.5, 9.7, 9.4, 9.6, and then 9.8, 9.6, and 10.1, 10, 9.8, 10.2, and slowly it goes like this, up and down thing, and then it starts to settle at the new number that is going to be your new normal. And 10.7 could be your new normal, or it could be still going up towards 11.5. It's hard to predict what that is, but it will settle at a new number if you have a parathyroid adenoma. If there's parathyroid hyperplasia, the number continuously increases, but in a more gradual way for most people. Now, based on your numbers, the fact that you have an elevated calcium and your PTH is not suppressed, I would say what you have is what we call normal hormonal hyperparathyroidism, right? And that's the state. So it probably has been going on for years. And if you started having symptoms 3 to 4 years ago, that's when it get large enough to produce enough hormone. The process probably started a few years even before that, okay? Yeah, I think you have the right idea. Yeah, I think you have a good understanding, Michael, of what this disease is and how it progresses. Unfortunately, it is, as you say, it takes years to develop. Kim Millett, Dr. Larian, thank you for your time. My pleasure, Kim. 3 years of running around in circles. Calcium is 2.74, 11, and PTH is 11.3, which is 106.4. Both very much elevated. Vitamin D low right now, but usually normal in the summer. These numbers haven't changed much over the 3 years. Creatinine is around 103. GFR, which is the functionality of kidney, is below 60, and that's low. Diagnosed with celiac disease, so malabsorption, gluten intolerance. May have had it for years. Nephrologist says it's not the kidney issue, but hyperparathyroidism. She wants it resolved. Ultrasound scans have been, well, you know, hyperparathyroidism taxes the kidney, so the more issues you have with it, the more likely it is that you're going to have problems in terms of kidney, because there's a large burden on the kidney. So your nephrologist is on the right track, of course. Sesame scan, last one done 2 years ago, negative. Ultrasound negative, except for one, but they did a biopsy and it was negative. Just one comment on ultrasound guided biopsy. Under the microscope, the parathyroid cells of a parathyroid adenoma or an abnormal parathyroid look very much similar to thyroid cells. So under the microscope, you can't tell the difference. The only way a needle biopsy is fruitful if you send the liquid in the needle or the material in the needle for PTH testing to check PTH levels. That's the only way you're going to be able to tell if what you biopsied is a thyroid or a parathyroid. So if they've done that and they said it was negative, then you have certainty that it was. If they haven't done that, then a negative needle biopsy doesn't really tell you anything. They now want to do a 4D CT scan in April. I know that's hard on the kidney. Your thoughts, please. Okay, so if the needle biopsy did do PTH testing, then you have really no choice but to do the 4D CT scan. If they haven't done it, obviously that's the place to go to repeat the needle biopsy and check for PTH. In terms of the 4D CT scan, I don't know what the creatinine of 103, I don't know what the parameters of normal are in the system that you're in, but if your creatinine is elevated, your nephrologist is the person to tell you if getting contrast for a 4D CT scan is feasible or not. If it's possible to hydrate you really well before, maybe give you intravenous hydration before or an intravenous hydration afterwards to flush out the contrast, if that's a feasible possibility that can work for you. And their nephrologist is really purely the only person who can answer that question. So that's the person I would turn to. If that's not a possibility, if the kidney cannot absolutely tolerate and they did PTH testing on a nodule they found and that's not possible, Then the other alternative is to do a choline PET scan and see if that's something that your kidney can tolerate. Again, your nephrologist will be at the center of this decision, and hopefully it can, and that'll be the other choice left for you to do. All right, my dear? Best of luck. This is a very tough situation. And if none of those are feasible, then the only option you have is to have someone do a bilateral neck exploration to look an exploratory parathyroid surgery, which doesn't sound like a great idea, but in the hands of an expert parathyroid surgeon, it's not a bad thing, okay? It can be done well, it can be done without a lot of risk, it can be done by minimizing the risk and with the possibility of good outcomes being fairly high, all right? Again, best of luck. Natalie Danoff. Hello, Dr. Larian from the Buckeye State. Hello, Natalie. Recently, I went through a series of tests at the Cleveland Clinic to locate an abnormal parathyroid gland, as evident through the blood work. The most recent testing was venous sampling, which resulted in further inclusive evidence as to the location of the gland. My doctor said surgery is not an option and to make an appointment to see him again in August. Okay. Previously in November, I had a SPECT CT scan and a neck with IV contrast. Okay. PTH is 161, calcium 10.9, vitamin D is 40. My surgery history: 1986, I had a left thyroidectomy. 2012, I had a right thyroidectomy and a parathyroid adenoma. 2014, I have a left lower parathyroid removed. Okay. And my question: do I wait till August to make plans, or should I consider other types of testing? The decision to take action really is based on how much this disease is impacting you, right? You have 2 parathyroids that have been removed, right? You've had both sides of your thyroid removed. You're not certain if you have one more gland left that's functioning or 2 glands. Hopefully you have 2 functional glands and only one of them is over-functioning, right? That would be ideal. But based on the fact that you've taken out 2 parathyroids already, I would probably say that you probably have had parathyroid hyperplasia to begin with, right? And the question that you should ask yourself is, did you feel better, significantly better, after any of these surgeries, and how long did it take before you started to feel ill again, okay? Because that tells you the potential of you having hyperplasia or an adenoma. Unfortunately, after having 3 surgeries in your neck in this area, the venous sampling is just not really helpful, because when you do surgery, when we're fetuses and our face and neck are formed, they're formed as separate pieces that merge and come together. They merge to make our nose. They merge to make the philtrum of the lip, right? So we have a separation of the 2 sides. So the thyroids on the 2 sides have different blood vessels that only come from that side, right? But once you do surgery and the body heals, you can have blood vessels that now cross over, right? And so that's what causes problems with venous sampling after you've had surgery, is because the blood vessels cross over. So when you get a sample here, you don't know if it's only locally from here or if it's something from here passing through to that side. So venous sampling becomes a problem after surgery. When you need it the most, it's the least helpful. So venous sampling in a virgin neck, in an untouched neck, works really well. In a post-surgical neck, it's not so helpful. I would say that at this point, the MRI probably not so helpful. The reason MRIs are not so helpful for parathyroid is because when they slice the MRIs, the distance between them is 3 millimeters. When you do a CT scan, it's 1 millimeter. It's very thin. So when you have a 3 millimeter MRI, you can have a parathyroid that sits in the middle of it and it can be missed, or you just see the tip of it and it's such a small portion, you might not be able to say that that's a parathyroid or not, right? So MRIs are not so good. The choline PET scan, the 18-fluorochlorine PET scan is an option. It's hard to do. I know that they do it at UCSF. I'm not sure if they do it at Cleveland Clinic yet. that would be an option. I would exercise everything I could to try to figure out. But the other thing to do is to see if during any of your 3 surgeries, the surgeons biopsied any of the other parathyroids. Because if they did, then you know the location of where those parathyroids are. If they biopsied them and said, so they took out your left lower parathyroid and a right-sided parathyroid. So if they biopsied the other 2 parathyroids, then you know the parathyroids are at least in the neck and not in the chest or in the throat. And so that can be helpful, because then if they did do that, then you know where the locations of those parathyroids are, then probably by looking at the CT scan, you can make a guesstimation of which one potentially is more enlarged and which one to aim towards. Or you may not even need to do the scans anymore. You just need an expert surgeon that goes in and says, okay, these are the areas. Now, being that this will be your 4th surgery, it should be the last and most definitive surgery. So you should do everything you can to do it. So I know I'm flipping here, but I think probably do the fluorochlorine scan as well. If there are anything that you see on ultrasound, maybe do a needle biopsy and send for PTH testing as well to see if there's any lesion that looks like parathyroid tissue, okay? Because being that there is the 4th gland, you carry a high risk of injury to the recurrent laryngeal nerve. You wanna be more informed when you go in there. This is a tough situation, Natalie. Hopefully what my babbling was helpful to you, okay? Joanne Gary, good morning, Dr. Larian. I'm hypocalcium for the past year since I had 3.5 glands removed. Yes. In April 2018, my calcium has been hypo ever since, not going above 8 to 8.2. My D3 is holding at 40, my PTH is 30, okay? In order to raise my calcium, my doctor wants you to use the calcitriol. I'm on board, however, we used it prior for a month and my PTH went from 40 to 20 in that month. She took me off due to swelling in fingers and puffy eyes plus stiffy joints. My PTH never really recovered its original 40 number and stays at 30 for the past 3 months. My calcium hasn't been able to get past 8. My usual calcium for the past 20 years and is in the 9s. My question is, will my last piece of parathyroid ever really work, or will the calcitriol keep my PTH very low and I become hypopara as well as hypocalcium? I'm a bariatric patient with malabsorption issues. And Joanne, that may be your source of your problem, because PTH of 30 is a pretty robust parathyroid hormone production, right? Now, it would be better if I had information what your labs you had prior to surgery to know how high your calcium and PTH were. And the other question I have is, how much do you have in terms of symptoms? Because if your calciums are holding at about 8 and you're not having a lot of symptoms of numbness and tingling and all sorts of symptoms that go along with hypocalcemia, maybe that's a right calcium for you. Maybe you're treating a laboratory rather than you as a human being, right? So the more important question is your functionality. If your functionality is okay and you're not getting symptoms, then I wouldn't try to push this thing and try to correct a lab. I would go based on your symptoms. If on the other hand, you're having symptoms and your calcium with 8 and 8.2 are too low for you and you're having problems with it, then obviously you're gonna have to try to get your system pumped up as much as possible. If you have had bariatric surgery and gastric bypass and you're having absorption issues, then you have to try to see if there are other ways for you to get calcium to your body, right? Yes, calcitriol does suppress the parathyroid system, but if you're not getting enough calcium into your body, or even a robust parathyroid system is not going to be able to correct your calcium because there's just not enough coming into your system, and it's going to try to get it out of your bones, right? Which is also not what you want and what you desire. So looking at other modes of getting calcium into your body, other delivery mechanisms, the liquids, trying to get the sublingual vitamin Ds and seeing if that absorption is better, potentially getting IV calcium here and there to try to supplement and so on. And so I mean, this is a very complex situation you're in, but the fact that your PTH is in the 30s is very encouraging that last remaining half a gland is doing enough to do the job, okay? Do you think my body is pseudo-hypo? Well, I don't think you're hypopara. I think you're hypocalcemic, and you're just not getting enough sources of calcium into your body. All right, Jojo. Hopefully that was helpful. Autumn Jolene. I had surgery for hyperparathyroidism in the beginning of December. They removed one parathyroid adenoma and one parathyroid that was embedded in the thyroid, originally believed to be a thyroid nodule. My surgeon found the other two and said they looked fine. But during surgery, my calcium remained elevated and my PTH only dropped to 59. Okay? I was told to take 2 times and a regular over-the-counter dose of vitamin D for 6 months. By mid-January, I was feeling horrible all over again, same symptoms, bone pain, nausea, constipation, night sweats, and kept an appointment with my regular endo, who didn't do my surgery, of course. She did blood work 2 weeks ago. My calcium was 11.8, vitamin D and PT were in the 90s. She told me immediately stop all supplements and will read blood work 2nd of March. Since stopping supplements, I've gotten even worse. Now I fear I have a kidney stone as well. Is it possible my surgeon missed something? Will I likely need to go through another surgery, or things get even out? If they might even out on their own, how long will it take? Okay, good questions. Hard to know the answer. Hard to know if the 2 parathyroids that your surgeon saw visually were actually parathyroids. Sometimes you can have fatty tissue called brown fat that looks like parathyroids. Sometimes you can have separated pieces of thyroid that look like parathyroids, or it could be mistaken. Sometimes you can have lymph nodes with fat around them that can be mistaken, okay? So there's lots of things. So without a biopsy, you don't know if what your doctor saw was actually parathyroids, right? That's one thing. Secondly, the fact that your PTH was at 59 doesn't tell me anything because I don't know what your PTH was originally. But if your PTH was 200 and it came down to 59, that would be an appropriate drop, and that would be the good choice to stop surgery at that point. But if it started at 100 and it went into 59, then it's not appropriate. So I'm not sure how to judge that number decline that you had. Some people who have hungry bone syndrome, they have a lot of bone loss, immediately after surgery will have elevations in their PTH because the bones try to grab all the calcium back. Generally, these patients have lower calcium levels, but it's possible that the parathyroid that remains and are working hard to make sure your calcium doesn't drop causes an elevation in calcium, and you are in a constant state of flux. The fact that you feel worse because you're not taking calcium supplements kind of supports the potential for hungry bone. So I think being off the calcium and checking your labs again is a good idea. I know you're feeling horrible, but if off the calcium supplementation, you get your calcium levels comes lower and your PTH goes higher, that bodes more for this problem being a hungry bone issue, right? And if that's the case, then all you have to do is supplement not quite as high a level of calcium, but another moderate level of calcium and monitoring it for 6 months. Usually at 6 months, things resolve, right? But if you're off the calcium supplementation, calcium vitamin D, and you check your labs again and your calcium is still mid-11s, and your PTH is still 90s with a normal vitamin D level, then you have persistent hyperparathyroidism and probably will need surgery. But even in that circumstance, I would say to still wait 6 months to see if the numbers have an opportunity to change, okay? And at that point is the right time to proceed with surgery. All right, my dear, I know it's hard to be patient in this circumstance and wait things to normalize, okay? The other question you have is, what is familial isolated hyperparathyroidism and what can be done for it? This is what my internet searches are leading me towards. Well, that means there's a genetic mutation that's not recognized yet, right? And so we don't know what the gene is, but your family carries it, right? And that gene is predisposing many members in your family to get hyperparathyroidism. So if there is, if you have a sibling and an aunt and a grandparent who had hyperparathyroidism, then potentially you carry this gene that predisposes you, and what should be done is that all of your family members should be tested for hyperparathyroidism by doing labs. All right, Autumn. Moving on to Jackie Booth. Hi, Jackie. Thank you for your time. My pleasure. I have 3 questions that many people have asked about. I hope that's okay. Let's do it. Have you ever come across someone with psychiatric disturbances due to normal calciumic hyperparathyroidism, or is it just with raised calcium? No, absolutely. I've had normal calciumic patients. I've had normal calciumic patients who felt like they were losing their mind completely, but the calcium after surgery became significantly lower. So they started in the normal range, but after surgery their calcium was much lower. But they also had a fairly high PTH level. So both PTH and calcium can cause symptoms. Okay. Can hyperparathyroidism cause permanent nerve damage? Yes, it can. And that's part of the controversy of asymptomatic hyperparathyroidism and when we should do surgery. Because if you imagine when there's a large amount of calcium in your bloodstream, it can crystallize into things, right? So if it does that into nerves, it can permanently affect those nerve functions. And the studies that make people say, I don't know if I had an asymptomatic patient, by asymptomatic meaning someone who doesn't have kidney stone or osteoporosis and really severe psychiatric symptoms, if they're helped by doing parathyroid surgery. And the question what we don't know is, does it stop the disease in the process? If you're not getting better, does it stop it from getting worse? And we still don't know that answer. I suspect that does occur, right? But we don't know, okay? But it can cause permanent nerve damage, How is nerve damage associated with normal calcium hyperparathyroidism? It's the same process. It's with normal calciumic hyperparathyroidism, what you don't know is this. Let me show you. Okay, so with normal calciumic, you don't know where your calcium starting point is, right? So if your calcium starting point is 9.2 and you go to 9.5, that's not much of an increase. But if your starting point is 8.5 and you go to 9.5, that's similar to starting at 9.5 and going to 10.5. So it's the degree of difference in calcium that really matters more than the actual number. Because if you are a person that's naturally has a calcium of 10.2 and hovers around here, you go from that to 10.5, that's not much of a difference. You're not going to feel ill. But if you start at 8.5 and you go to 10.5, you're going to be severely ill. So this number itself doesn't tell you as much as the difference does, right? And in order to achieve that difference, you need a higher amount of PTH to get you from here to there, right? So the fact that people are in normal calciumic is not as telling as how much of an increase that is per normal. Now, when someone has a calcium of 11.5, they must start either from somewhere in here. So they started from somewhere in here to get to that number, right? So yes, obviously when you have a calcium of 11.5, you're more likely to develop problems and issues, right? But because you probably started at a much lower rate, right? But again, it's really the difference that dictates, So if someone has a natural calcium of 10.2, right? And then they go to a calcium of 11.2, they may not be as sick as someone who starts at a calcium of 8.5 and goes to a calcium of 10.5. Even though the number is different, the difference here is much less than the difference there, okay? So normocalcemic doesn't really matter in that equation. It's the difference in numbers that really is meaningful, okay? Jackie, hopefully that helps. Kelly, let's flip this around. Kelly Witkowski. Hi, Dr. Larian. I'm 37 and new to this. Yes, of course. Fortunately new to this. Was diagnosed with primary hyperparathyroidism last September. I had my consult appointment with the surgeon in March 10th. My numbers range from 10.4 to 11.2 for calcium and PTH of 57 to 90. I had an ultrasound done and a nuclear medicine count, and no adenoma showed up. You mentioned nuclear medicine scan is good for PTH levels above 150. And 40 CT scans are better for PTH levels below 100. Should I push for a 40 CT scan? Absolutely, my dear. The more information you have before your surgeon goes into the operating room, the more likely it is for you to have success, the more likely it is that your surgery will be more minimalistic. You know, when people talk about minimally invasive parathyroidectomy, everybody thinks we're talking about a small incision. I am talking about, not everybody, but I am talking about being minimalistic under the surface, right? The less I do under the surface to cure you, the less side effects, complications, potential future issues you're gonna have, right? And so it's important. So if you can get the 40 CT scan, I encourage you to do so. As of now, I'm getting exploratory surgery. It makes me nervous. Also, what question would you ask for the surgeon when we meet? The question I would ask is how many parathyroid surgeries they do, right? If they're using intraoperative PTH or not. How are they assessing the functionality of the other parathyroid glands? Are they doing it by looking at it? Are they doing it by radio guidance? Are they doing it by PTH testing, okay? And obviously there's a lot of controversy about that, but I think what you have to do is figure out which one of those techniques makes more sense to you as an intelligent person, you know? And that's a hard thing to do, but you just have to go through the reasoning for it. Obviously, I feel that PTH testing works better in my hands. Others feel that radio-guided surgery works better in their hands, and others feel that looking at all 4 glands, and some feel like doing a combination is what makes most sense, you know? And you gotta figure out which one of those makes more sense to you. Is there a way to tell how long I've suffered from this? The only way to know is if you had calcium levels done in the years past, and you see it hovering at this number and then starting to go up. And that's the only way. That transition point of it going up is when you know this disease started. Wish I could afford to see. I don't know what to say. But I'm sure I can help out. Anyways, best of luck to you, dear. Bless you as well, my dear. Best of luck. Michelle Jankowski, 44 women from California have calcium of 10.0. Okay. Have a calcium of 10.0, other of 32, vitamin D of 18. Hyperparathyroidism, or should I try to raise my vitamin D? 44-year-old woman from California, I would assume, have a calcium of 10, PTH of 32, I guess, what you're saying, and vitamin D of 18. Yes, I would suggest absolutely. Your numbers are in the normal range. Your calcium is high normal, your PTH is mid-range to a little bit lower than mid-range. Vitamin D is 18, which is low. The first thing to do is to try to increase your vitamin D and see how you feel, if you feel actually better, because your calcium and PTH numbers are not abnormal. So to see how you feel. Vitamin D in and of itself, with low vitamin D states can cause problems. So that could be the reasoning for any symptoms that you may have. So that would be the first choice, my dear. Amna Khan. Hello, I was wondering, how do we know when to go from observing secondary hyperparathyroid to seeing it as normal calcemic? As most doctors want to observe when the calcium is not too high. I've been told to wait and observe for years. Okay, let's see what you got. So calcium's ranging from 8.9 to 9.8. PTHs ranging from 46 to 94. So the last calcium you have is 9.0 and 88 PTH. Prior to that, January of last year, calcium 9.5, PTH was 46. Prior to that, 9. Okay, so let me see if you give more information. So the numbers are pretty much the same. Usually elevated PTH levels and almost always calcium's in the normal range, the lower normal range. No vitamin Ds, but if their doctor is thinking it's secondary, then I'm assuming that you have low vitamin Ds. If you correct the reason for having secondary, right, and your PTH doesn't come down, then you have normal calcemic hyperparathyroidism, you know. And if you have normal calcemic hyperparathyroidism and you have symptoms, or you have kidney stones, or you have osteoporosis, then you should take action, right? And that's the basics of it. Sitting and waiting is only good for someone who has whatever diagnosis of hyperparathyroidism, now be it normal calcemic or hypercalcemic or whatever, right? Has no symptoms, their quality of life is not affected, has a bone density study that shows your bones are totally healthy and appropriate for your age, has scans of their abdomen that shows that there's no kidney stones, their kidney function is normal, everything's okay. So if you have absolutely no symptoms, no bone loss and no kidney stones, and your kidneys are functioning perfectly, that's when you can sit and monitor, right? And if you see any change in those parameters, then you can take action. But otherwise, if you're having symptoms, right, and you have normal calcemic hyperparathyroidism, then you should have it rectified. If you have symptoms and you have secondary, then if you have secondary regardless, you got to correct what's causing the secondary. So managing secondary is exceedingly important. So I think that's what I would aim for. Either manage secondary so you don't have secondary hyperparathyroidism, and once you've corrected whatever cause could be causing a secondary, if your numbers don't normalize and your PTH continues to stay elevated, then you have normal calcemic hyperparathyroidism. If you have normal calcemic hyperparathyroidism and you have symptoms, or you have kidney stones or bone loss, then you should take action. All right, that's my thought on it. Others may not agree, but that's what I think. Linda Nesvik. Hi, Dr. Larian. Hi, Linda. What to do if the glands are atypical and reactive? The histology reports from pathology after the second operation sets up. Had 2 surgeries in 2016 and 2018. Blood tests are now normal, but all the symptoms are back. All 4 glands have never been checked under the surgery. Okay. There is a concern for someone when they have atypia of their parathyroid that they're developing a parathyroid cancer, right? Usually under the microscope, they see fibrous bands when the tumor is cancerous, is in the early stages and heading towards it, right? But people don't develop parathyroid cancer in multiple parathyroid glands, right? So if you have atypia in one gland, it doesn't mean that the other glands are precancerous, first and foremost. If you're having symptoms, which you have to, especially if you've had 2 surgeries, if your numbers are not going up like they used to before your 2 surgeries, and the numbers are staying in the lower range, and they're appropriately suppressing each other. So when your calcium goes higher, your PTH goes down, calcium goes lower, PTH comes out, then probably your parathyroid is not the source of the problem. You definitely should look into your thyroid gland functioning, because after 2 surgeries, there can be significant scarring of the thyroid. There can be scarring around the blood vessels that feed the thyroid, and the functioning of the thyroid gland can diminish. So you have to look at other hormonal systems to see if they are also having an impact, if your parathyroid numbers seem absolutely normal, okay? But if the parathyroid numbers don't seem normal, if your calcium is high normal and PTH is high normal and they're staying both up here, then you have persistent hyperparathyroidism, and you may need to have further surgery to address it, all right? Best of luck. This is a tough situation to be in. Sarah Allen. Hi, Dr. Larian. In order to help doctors diagnose hyperparathyroidism more efficiently, is it possible for the medical profession to start testing PTH as part of the standard CBC? Well, not the CBC. CBC is a complete blood count. It looks like white blood counts or red blood cells and platelets. But as I think doing it as part of a basic metabolic panel, looking at calcium and monitoring calcium would be a good idea, right? PTH testing is probably more expensive, and that's why they won't do it as a routine, especially when the healthcare system believes that the chance of getting hyperparathyroidism is 1 in 250 women over the age of 50. It's so low, and 1 in 800 people, when they believe those numbers, right, which are not actually true numbers, but when they believe those numbers, with the chance of this disease being so rare, they're not going to want to put the money into or invest the money into testing everybody for it. But calcium can be part of the routine, and what should be done is an education of doctors and patients, right, as their own advocates, that, and I think some of the parathyroid websites do a good job at educating patients at least, that if you are having these symptoms that are non-specific, calcium should be looked at. And it shouldn't be that you just look at one calcium number, you trend the calcium. And if you see that in the normal range, your calcium over the course of months and years is creeping up, even in the normal range, then you should pull the trigger and do PTH testing. I think that's a more reasonable thing that a healthcare system is going to be likely to do, rather than do PTH testing every year with annual exam, which I'm certain a system won't do. Most systems won't do it, unfortunately. Laurie Nickel also mentioned magnesium to both serum and RBC. And again, it would be ideal, but testing those things are expenses that all really depends on a healthcare system that can afford it, can justify it. And I'm not defending anything. I'm just saying, it's better. Education of doctors and patients is more important than doing just routine labs, right? And getting educated doctors who can say, yeah, you're having these set of symptoms. Yes, it could be chronic fatigue, it could be fibromyalgia, it could be anxiety, it could be depression, it could be, hormonal changes what happens to women as they're going through menopause, but it also could be hyperparathyroidism. And I should look at that as well. It should be part of a differential of someone having a set of symptoms, right? That could be any of those things, but also could be hyperparathyroidism. Gret Hansen Stenquist. I'm 65 years. During the latest 3 to 4 years, I've become extremely sensitive to histamine, mostly food and to medicine. For example, I react to very small doses. I wonder if could be a connection in parathyroid problem and histamine intolerance. I just learned that my calcium PTH are increased. Yes, there actually is, ironically. And I've had 2 patients who have had histamine issues, and they had expert doctors in the histamine issues. And when I spoke to them, those doctors told me that elevated parathyroid hormone levels affected the histamine condition and made it more severe. So, I mean, I can't say that I'm an expert with 2 patients, but there seems to be a connection with the histamine issues and parathyroid hormone release. And so that is definitely a possibility. I would look into it. If you're having elevations in your calcium and PTH and you're having histamine sensitivity, that may be one reason to proceed with taking care of your hyperparathyroidism. If you had asked me this question a year ago, I would not have been able to answer that question. It just happened that I've had 2 patients in the last year with that issue. So again, I'm learning right along with you guys. Vicky Seabrook Pankshuk, sorry to massacre your name. After having my 4th and supposedly last parathyroid gland removed this month, where would you look next for the 5th or leftover pieces? Note, I did not go hypo, so that something is there. I've had 3 parathyroid surgeries I'm a complicated case, clearly. The right side of my thyroid was removed during the first surgery in 1993. 2 of my 4 glands were diagnosed as atypical in pathology report. Both atypical powers were from the right side. One had been auto-transplanted into my left neck muscle before it was found to be atypical. That was the last one removed. How would you proceed with my case? Oof. Okay. So I'm assuming the 4th gland that was removed, or your 4th surgery, was when they removed the muscle of your neck and they found the parathyroid. And hopefully this parathyroid, having been there since 1993, it's not a cancerous parathyroid. And if it's not, which is what I'm hoping for, and most likely the case, then I don't know if the atypia means too much, right? Now, having said that, you clearly have extranumerary parathyroid. Now, extranumerary parathyroids happen, let me show you, because parathyroids migrate from pouches in your throat. So the first pouch gives you the ear, second pouch gives you the tonsil, third pouch gives you the lower parathyroid and the thymus gland, and the 4th pouch gives you the upper parathyroid. So these migrations are meaningful and important, right? Because although 80% of the time they migrate to be around this area, another 20% can be anywhere along this path. They can stay up here, they can overshoot and be here or inside the thymus, and they can be all the way down in the chest and sitting right on the heart, right? They can go a little laterally, right, and be here. They can be in a lot of places. And there can be multiple, right? You could have, as the parathyroid is going down, it can leave pieces behind. And there is this condition called parathyroidism, where the person has multiple parathyroids everywhere, right? Inside the thyroid, outside the thyroid, everywhere. So I think the scans that I would suggest doing is, I would do an ultrasound, because if a parathyroid is inside the thyroid gland, the ultrasound is the best test to be able to show that possibility, right? I would also do a 4D parathyroid CT scan to see, that would be the sequence, right? So 4D parathyroid CT scan would be my next choice to see if there is something elsewhere, or if there's multiple lesions that look like likely candidates. And if neither one of those show anything, then I would resort to the choline PET scan to see if that can have a chance of showing it. If your PTH numbers are not above 150, I don't think the sestemi B is a good choice. But if nothing else shows it, I would still do that. I would do everything I can to try to see if you could find the 5th parathyroid, or maybe more than 5th, 6th, 7th, 8th parathyroids, okay? And that's how I would proceed. If everything is negative, right, then you may need extensive neck surgery to clear out the compartments in your neck to try to rectify the situation, right? But very difficult thing to do, having been your 4th neck surgery, okay? So definitely get an expert surgeon to do your surgery if you're heading down that way. Or actually, anyone who is gonna do your 5th surgery should be an expert surgeon. And hopefully all your 4 surgeries were done by an expert, because that person would be the best person to know the anatomy of your neck, and you can proceed with them, okay? Best of luck. I don't think I was very helpful, but I did try. Triphenylidine. I've been told, but my calcium levels have dropped in the last few months. They've been steadily increasing since late 2015. So my surgery is now being delayed. What could cause this? Gold Coast, Australia. It is not your calcium levels that are meaningful in and of themselves. It is the combination of your calcium, PTH, and vitamin D, okay? So if your calcium levels were a little higher and your PTH was high, but your vitamin D was very low, and by supplementing vitamin D your PTH came down, your calcium came down a little, then you had secondary hyperparathyroidism, and you don't need any surgery, right? But if on the other hand, your calcium is coming down a little bit, vitamin Ds are in the normal range, and calcium coming down means your PTH went higher, then nothing has changed. You just had some occasions when your calcium was lower and your parathyroid gland is still over-functioning to try to compensate, right? So it's that relationship between the three that actually tells you the story, not just the calcium number. Trifina, it's hard. These things can be hard when the doctors are not looking at all the parameters to make a decision for your health, all right? Good luck. Francis Push, sorry I missed your discussion on February 25th. I would so appreciate a clarification that I'm unable to get from my physician in New York. If postmenopausal women have a serum calcium of 10.1 and a PTH of 60, is there a problem? DEXA scan revealed osteoporosis of one hip. I have rapid pulse out of nowhere with slight exertion at the time and high blood pressure that fluctuates. My understanding is that that we age, our serum calcium lowers after 40-ish, should be in the 9s. No, that's not true at all. You're born with a genetically one number for calcium. All your life, you're going to continue to try to maintain that calcium level, right? Because your genetics don't change, right? When the genetics of your parathyroid gland, which make the calcium sensing receptor, make it be sensitive to a certain calcium level, right? And that sensitivity doesn't change with age, right? Your nerves get used to a certain calcium level. Let me flip you around again, right? So the way nerves function is that signal goes down the nerve and comes to the endpoint, either to a muscle or to another nerve. So when the signal comes down and gets to the endpoint, right, calcium channels, these green channels open up, and calcium from the outside rushes inside, right? So if your body wants your calcium to be 9.0, and all your life has been used to a 9.0, and it wants to send the signal magnitude 90 here, it'll open up 10 calcium channels, 90 calcium elements come in, and based on that 90 calcium elements, an equivalent of magnitude 90 number of sacs that hold serotonin, dopamine, whatever chemical that your nerve is producing, and that chemical goes to the next nerve of magnitude 90, right? If, however, your calcium is, instead of 9.0, is 10.5, and you open up 10 calcium channels, now the amount of calcium that comes in is 105 rather than 90, right? And the signal that goes through is 105, right? And so that signal is an inappropriate intensity of signal, right? And that doesn't change. Your nerves, not every system in your body doesn't change, right, as you age to change your calcium. It doesn't make sense for your body to go through such a dramatic change, right, all your life, and trying to be playing catch up to what new calcium. So your parathyroid's completely changed. Your nerves changed. All the cells in your body change to new numbers. That's not what happens. Your body is set for a certain calcium. There's no reason for that calcium to change, right? The density of your bones change, but the amount of calcium in your bloodstream doesn't, right? Now remember, the amount of calcium that's in your blood represents only 2% of your calcium. 98% of your calcium is in your bones, right? So the amount of calcium in your blood actually is not even 2%, it's less than that. The amount of calcium that's everywhere else in your body, outside of your bones, is 2%. The amount that's in your bones is 98%, right? So that level that's in your bloodstream is meaningful and important because every cell uses changes in calcium concentrations to send a signal. Okay, so getting back to you. In addition, the PTH should have a reverse correlation to calcium, which means 60 would indicate an issue. Am I correct? Yes. The fact that you have a calcium on the upper side of normal and a PTH of 60 indicates a problem. But I would say that in your circumstance, I would not trust one set of numbers. I would track it out. I usually actually get multiple numbers, maybe 3 or 4 sets done. I would get calcium, PTH, and vitamin D on 3 or 4 separate occasions. I would do all of them fasting in the morning, because PTH levels have a twice daily surge, right? So you don't want to do it at different times to be affected by that, a natural rhythm, right? You want to do it first thing in the morning before anything changes, before you eat, before any external factors affect you, before you exercise or anything else. You want it to be same exact. And I would look at it on those 3 to 4 occasions and see what those behaviors are. And if you continue to be high normal all 4 times, then there's a problem, right? But if you could show that one time you're 10 and 60, and another time you're 10.2 and you're 20, another time you're 9.5 and 45, then there's a play, and it's an appropriate play, and you don't have hyperparathyroidism. So I would do it more than once. I'd gladly have it checked, but 2 physicians, both internal ones, said it was fine. I'd prefer to get guidance from an expert. Yes, you need more numbers. You need more data points, Just one data point is just not enough to do it. At least do several other ones, okay, my dear? You'll get a better answer and more solid answer, one way or the other, you'll know. Sally JP, hello, Dr. Larian. I'm asking this one for our UK members. Do you know why a surgeon would cancel surgery for a patient with elevated blood sugar? Yes. If they have elevated blood sugar and they have diabetes that has not been diagnosed or controlled, then they could get into stressful issues with surgery and go into diabetic crises, right? And so they need to make sure the sugar is handled, because surgery puts a heavy burden on the body. And if you're a diabetic patient and you're not controlled and you're unrecognized, you could go into serious complications from it. So it's better to control the sugar and figure out what the sugar elevation was before having a surgery done. In most cases, parathyroid surgery is not an emergency and can wait to rectify the sugar issue. Okay, good question. Lauren Hutchison. Dr. Larian, thank you for hosting. Yes, my pleasure, Lauren. I found out about hyperparathyroidism by looking for the cause of symptoms I've been experiencing. I've downloaded your worksheet and identified with almost all of the symptoms on your checklist. I'm so glad that worksheet is helpful, especially kidney stones, brain fog and fatigue, memory loss, headaches, anxiety, acid reflux, stomach pain, constipation, and frequent urination, as well as nighttime urination. I've only had 2 PTH and calcium labs done. Calcium 9.5, PTH 42, vitamin D 30. Second one, calcium 10.1, PTH 48, no vitamin D because I could not convince my PC, primary care doctor, to do it again. Yes, of course. Is there any chance at all that my symptoms could be due to hyperparathyroidism? Yes. My doctor says I'm fine, but can't help me find a reason for any of the symptoms I'm experiencing. I've read about biochemically normal hyperparathyroidism. Could this be the case for me? Yeah, it could be, because a lot of times the people who are biochemically normal, they're in the process of elevating. So, your calcium was 9.5 one time and PTH was 42. So your calcium was mid-range of normal, right? Consider my head the range of normal. So calcium is mid-range of normal, your PTH was slightly on the upper side. Your calcium goes higher, instead of your PTH going down, your PTH is a little higher, right? So I think this is a trend that you need to follow, because if you continue to test these and these numbers are doing this thing, then you're having hyperparathyroidism. The other thing I would suggest doing is getting calciums from years ago. So if 10 years ago you had calciums that all showed up in 8.5 to 8.8 range down here, and now you're doing this thing, then that's a significant elevation. That also gives you more reason to follow and pursue this thing, okay? I'm desperate to feel better. I haven't felt like myself in quite a long time. I feel like I've aged 20, typical symptoms. But again, you need more information. I understand these doctors don't want to do it again because your number's in the normal range, but either sit them down and ask them, why did my calcium go up and my PTH go up, right? That's what someone did to me, right? That very question is what what convinced me that I didn't understand hyperparathyroidism 17 years ago now, right? A very smart woman sat me down, took the time, and asked me, son, I know you're smart, but explain to me why this is happening. And in my limited smartness, I could not answer the question at all, right? I was stumped. And I tried to come up with answers. None of them made sense to her, and clearly none of them made sense to me either, because that's put me on the path of trying to figure out this disease, which I clearly figured out I didn't understand. I just was a technician who was doing surgery, okay? So please set the question forth to them and let them think it through, right? And if they can't do it, and if they just refuse, change doctors, get labs done, and try to look at your trend. Good luck. This can be a hard one, but you can also educate your doctors, and you can set them on the path of understanding something they haven't spent time to think about. Lenny Thostrup. My name is Lenny, writing to you from Denmark. Hello, I hope I'm saying your name correctly. After many years of struggling and fighting with the healthcare system, I've finally been diagnosed with primary hyperparathyroidism. I have a pair of questions to which I'm hoping you got some answers, hopefully. Firstly, the doctor refused to refer me to a surgeon, as he holds the opinion that the probability of improvement from surgery is far from likely. He even suspects that I would be worse off. Instead, he wanted to prescribe medicine to lower the calcium levels. What's your opinion regarding the efficiency of surgery, and do you have any rough estimates on the share of patients who improve after surgery? Second question is, I have a high level of B12. Is there a correlation between this value and primary hyperparathyroidism? Thanks in advance. Lenny, I have not seen a correlation between B12 levels and hyperparathyroidism, so I don't know if there is. I would try to figure out why that is and correct it, right, and see if the symptoms improve. On the other hand, in terms of your hyperparathyroidism, one of the studies that is considered to be a very important study in the world of hyperparathyroidism actually came from the Nordic European countries. I think Denmark was involved with it as well. Denmark, Sweden, and Norway, I believe. And what they did is they took people who had only slight elevations in calcium, and these were patients who came into the hospital. They had a blood test done, and they were identified as having hyperparathyroidism, mild hyperparathyroidism, right? Because the calcium numbers were not very high. They were not separated by patients who had symptoms or not. They just had mild hyperparathyroidism. Some of them had come in because of symptoms, and some of them had come in without symptoms, and they had labs done that showed this, right? And I don't know how this was done. Half of them were told to have surgery, and half of them were told not to have surgery, right? I don't know if you could do that in the US, but this was done. And then they were followed for 2 years to see. And when they were followed for 2 years, at the 2-year mark, they checked their symptoms, and they found that the two groups, the ones who had had surgery and the ones who had not had surgery, had no difference in their quality of life symptoms. Now, there are some issues. I mean, this is very telling, right? Half the patients who had hyperparathyroidism with mild calcium elevations, and half that didn't have surgery felt the same at 2 years, right? When you looked at the whole collective, right? And that's really alarming, right? And that's what's used by a lot of endocrinologists to say, when you have mild elevation in calcium, it's better not to do surgery, right? And it's true sometimes, and I have done this. Sometimes I've done surgery and the patients have felt worse, right? But I found that in almost all those patients, there was other underlying disease processes that had been compensating, right? And the hyperparathyroidism had been compensating. They had this disease for a long, long time, right? And didn't know about it. And once this was addressed, right, because this had been a compensated state, all of a sudden things changed here, and then the other disease took over, and the opportunity to compensate had not been there, and took years and years before these patients felt better, right, because they had to compensate again, right? So that possibility also exists, And so in patients who have mild numbers, you need to look to see if there's other conditions present and look at that. And look at the whole patient as a whole. But what this study didn't do is stratify patients by them having symptoms or not, right? So if a patient is having symptoms, do those patients feel better as compared to the patients who didn't have any symptoms, right? And that would be an important bit of information, because if they had separated patients with the ones who are having symptoms, and those patients also had no improvement, then that's an important fact that we should know about. And that wasn't done. And there's no study that has shown anything like that. There are lots of studies show that patients get better. There are lots of studies that show patients don't get better. So it's hard to know. When it comes to what we call as mental symptoms, right? Or the other symptoms. Not bone pain, not bone loss, osteoporosis, not kidney disease, not severe psychiatric symptoms, right? So that's probably the reason why your doctor is not referring you to a surgeon. But I would say that if you are having symptoms, you should have treatment, right? And you should look at all the other causes, look at all your other hormonal system, the thyroids, your brain, the glands in the brain that produce hormones. Look at prolactin levels. Look at the sexual hormones, the LH and FSH, and look at adrenal glands. Look at all the other systems to see if there is an imbalance in the other systems as well that need to be corrected and justified. Okay, but these are very good questions. And I'm trying to give you as comprehensive of an answer to this question as possible. It's just that there's not a lot of studies. And that one study is the one study that a lot of people use to say, no, you shouldn't have surgery. And I just don't think that was a complete study either. It was a very good attempt, but I think if they can look back at their data and separate between the patients who have symptoms or not, they would get more information. They also did a quality of life survey that was a general quality of life survey, wasn't a specific parathyroid quality of life survey. And so that would be important to do if looking at that category of patients. So Lenny, hopefully that helps, but if you're having symptoms, I encourage you to take action. Janet Handley. Hello, Dr. Larian, thank you for your time. I have 2 questions if you get a chance. One is moderately high calcium and high PTH profile with nothing identified on ultrasound or nuclear scan suggestive of hyperplasia. Again, if your PTH is not, you actually give me numbers. My typical blood test, PTH is 20, upper limit of normal is 7.6, that's fairly high. Calcium is 2.6 to 2.7, range of normal is 2.2 to 2.6. Vitamin, very low vitamin D, 17, and now up to 45 with supplements. So your vitamin D, you normalized it, but your calcium and PTH didn't. Well, this is a good question. I would also do a 4D parathyroid CT scan if I were you, right? Because I have seen, even with the higher PTHs, that sometimes some of the scans miss it and a 4D CT scan can't find it, right? So I would do that. But if that one is negative, then there is a very good chance that you may have foregland hyperplasia. And your next question is, in case of hyperplasia, what is the probability of hypoparathyroid outcome? What are the issues associated with this, and do you recommend surgery for hyperplasia cases? Yes, absolutely. I mean, I recommend surgery based on the impact of this disease on your body. So if you're not having symptoms, if your bone density is totally strong and appropriate for your age, you don't have any kidney stone, the kidney function is normal, then I'm not sure what the role of surgery would be for you, right? But if you are having symptoms or you're having bone loss or kidney issues, kidney stones or any of those things, then you should have surgery. And you can do the surgery in a conservative way. And let me explain why. So, again, the traditional way of doing a parathyroid hyperplasia surgery was to remove 4 glands and take half of one of the glands that was removed and put it into the muscle, the autotransplantation. I rarely do that. I've never been a fan of this surgery because I've always felt that the chance of an autotransplantation at 80% working is too low, right? 20% of people being committed to hypoparathyroidism was too much of a loss for me. I prefer either 3.5 gland removal while leaving the smallest gland in place with a blood vessel feeding it, right? Or 3 gland parathyroidectomy, leaving the whole gland, right? So either leaving a whole gland or half a gland. And the decision between these two has to do with the size of the 4th gland. So in this case, I probably would have left this gland in place with the blood vessel intact and maybe taken out 1/3 of it, right? But if this was the last gland that was left behind for me, I probably would take 2/3 of it off and leave it in place, right? And during the surgery, I would do PTH testing. So let's say this is the surgery, right? So let's say I do only a biopsy and remove only this much. Let me do it in a different color. I remove that much, right? And I leave majority, like 80% of this gland. I do PTH testing during surgery, right? And I'll check to see if my PTH numbers are coming down or plummeting down. If the PTH numbers plummet down, then I would auto-transplant the last one. If the PTH numbers don't plummet down, right, and stabilize at a number, then I would think that the parathyroid is producing adequate amounts of PTH to be functionally okay, you know? And that still is not 100% guarantee that the parathyroid will work, but it's more than 80% likely to be successful, right? You know, hypoparathyroidism is an unfortunate reality of parathyroid surgery. It is really unfortunate because you're replacing one problem with another. And we as parathyroid surgeons try to do everything we can to prevent that, you know, and just blindly auto-transplanting unfortunately doesn't do the job because you don't know if that parathyroid gland is going to take or not. And that's an uncertainty that I don't like, right? And this is something that I've learned over the years to try to do, you know, and many people, you'll ask 10 parathyroid surgeons and they all do different ways of trying to prevent this, which tells you that there's not one good way, but you know, pick a surgeon that the way they think about this and the way they try to do this makes sense to you as well, all right? And to decrease the chance of getting hypoparathyroidism. But it's possible to minimize that risk, all right? It's not 100% possible, but it's still possible. All right. Hopefully that helped, Janet. Lucas D'Angelo. What is your opinion on 18-fluorocholine PET scans for the localization of parathyroidomas? It's a newer study. I don't have a lot of experience because there's only one center that I know of in the United States that does it. And so there's not enough data for me to know. But it is another modality, you know, and anything to help us in this very complex, unusual disease it's useful. So if you've done all the other scans and they're not showing it, I personally would do that for myself if I had this condition. It seems to be quite a new procedure and I've read a few very promising studies about it. Also, in the case of very uncertain diagnosis, does imagery in general help the doctor at all to be sure? Is it only used for localizing? Well, you're very good and smart questions, right? Generally, I like to use the labs to give me the diagnosis, but not everybody has certain labs numbers. So when someone comes in, you know, and they have a lot of symptoms, and they are, you know, they look like the textbook hyperparathyroid patient in terms of their blood tests. They may come in with kidney stones, multiple kidney stones, have a, 35-year-old with 20 kidney stones has had many of the symptoms, right? But your labs are in the normal range. They're not suppressive, but they're in the normal range. Oftentimes what I tell them is that I don't have certainty. I can't tell you with certainty. If I didn't have the labs and looked at you as a person, I'd say you have hyperparathyroidism, but the labs are not giving me the same picture. Those are the times when I do the scans to see if I have a target. Because if I have a target for them, then it's an easier decision for both them and me to proceed with surgery. But if I don't have a target, and they may have hyperplasia, and that's why I don't have a target, but that makes it a harder decision. And these patients really have to take a leap of faith and really just kind of look into themselves and see, did my symptoms start from nowhere? I had no medical issues and nothing came up, and my symptoms started all of a sudden with no other things. I didn't change my diet, my lifestyle didn't change, nothing else changed. I've looked at every other possibility, ruled out every other reason for me having these symptoms, and this is it. I want to take a chance on surgery because my quality of life is very much affected. And that the most important thing is that quality of life. And the patient is the one to make that decision, balancing the risks and benefits, and really talking to your surgeon, getting information, and when you don't know, if the doctor is not clear, keep asking questions until you get enough information to make that decision, because during those circumstances, the doctor can't really make the decision for you, because how you feel is how you feel, right? And a doctor can only judge that so much, right? So hopefully that helps, Lucas. But yes, in circumstances when the calciums are not clear, the labs are not clear, I may use the localization scans to help me decide if the patient may have hyperparathyroidism, or it's likely that they do, okay? So you go on to say, for example, Mike, I have heavy symptoms for 2 years, high calcium with PTH right in the middle of the range. So my doctors just aren't sure. Well, you could have normal hormonal hyperparathyroidism. That's not an unclear case. What they have to do is rule out all the other causes of high calcium, right? Do full set of blood testing to look for things. Get ACE levels, PTH-RP, 24-hour urine calcium. Do a whole slew of testing to figure out if there any other cause of hyperparathyroidism exists. Look at the bones, make sure there's no bone disease, there's no bone cancers, there's no bone tumors that have spread to the bones, multiple myeloma. You do an extensive study to see, and if everything else is ruled out, then you have normal hormonal hyperparathyroidism. That's not an unclear case, okay? Ultrasound showed something, Histamine was equivocal. Yeah, Histamine would be. Your PTH numbers are in the normal range. Your PTH numbers have to be high for that. I would say the next test to do is a 4D parathyroid CT scan. Oh, they've referred you for a PET choline. You must live in England. Do the PET choline, see what they show. But a 4D CT scan is not a bad idea either, okay? All right, I just got a signal that I have a patient in the office that I gotta go. Let me see how many more questions I have. I'll try to punch through I had one parathyroid adenoma removed in 2017. Some symptoms got better, but bone pain has not. That's alarming. Just telling you, I was diagnosed with 2 parietal meningiomas. It seems that the meningiomas can be caused by hormones. So my question is it possible that meningioma is caused by parathyroid disease? I've had 2 patients who've had concurrent meningiomas and hyperparathyroidism, and one of them is convinced that they're connected. But I don't know. I haven't seen any literature to connect the two. And at 2, in all the parathyroid surgeries that I've done or parathyroid patients that I've seen, that's not a high enough number to convince me that there is a connection. But at the same time, not all patients are looking at their brains to look. So it could be a higher number. We're just not testing for it. Kate Ryan. I've been feeling ill for 2 years. I saw an endo and she thought my problem was vitamin D deficiency, prescribed 800 international units a day for 2 months. No change. I feel like a walking dead, bone ache, pain in body, shingles, painful skin, insomnia, always tired. I also have hyperthyroidism and take 50 micrograms of liver. So you must have hypothyroidism to take thyroid supplements. Doesn't help at all. I still have nodules on my thyroid, which so said probably benign, but would she know as never did a biopsy? I'm desperate now. Feel like I'm dying. Doctors don't know what to do. But you need to check your calcium and PTH levels, my dear. You need to check calcium, PTH, and vitamin D to see what those numbers show, and then you can get an answer, okay? And you can at least see if your parathyroid is the problem. In terms of the nodule in your thyroid, if your thyroid gland is low functioning and you're taking supplements, and that nodule on ultrasound looks benign and there's criteria for no, then you don't need a biopsy. But if they have some suspicious features, then they would proceed with biopsy, all right? But you need more blood tests for your parathyroid to be cleared up. Kelly Flanning, hi Kelly. A family that had thyroid cancer surgery to remove the gland. In passing, he mentioned that he takes 6 tubs with 1,000 milligrams of calcium a day, and that if he doesn't, he's in trouble. He said that calcium regularly is associated with the stop. He said, I got a phone call. He said that the calcium regulators associated with that stopped working. Is it possible that surgeons removed his parathyroid glands during the surgery? If so, is that considered standard practice? Because that seems kind of nuts to me. Hard to know, right? But yeah, I mean, if after surgery, he now has to take high doses of calcium to function, then the problem is he has low functioning parathyroid. It's not the intention of surgery to remove all 4, but sometimes it happens based on the conditions of the thyroid gland, the association of the parathyroids with the thyroid, if there is inflammation or thyroiditis that makes the area look so inflamed that it's hard to find the parathyroids, and the surgeon's experience. But you know, the lab tests would show it, calcium, PTH, and vitamin D. All right, trying to get through these things. Teresa Manshak Holman. I was diagnosed 20 years ago with Graves' disease. Hyperthyroidism. My levels have been normal now and show slightly high sometimes. My thyroid is fairly large. They're enlarged based on the size. My thyroid has started squeezing my trachea and it feels like I'm being choked. My recent ultrasound show subcentimeter nodules with increased vascularity, which concern me because I have a strong family history of thyroid disease and thyroid cancer, and my PCP just discovered a mass about 3+ centimeters on the left side of my neck over my carotid artery above my thyroid. I'm scheduled for a CT scan. I want the doctor to see what's going on with my thyroid because it is in the last year that's strangling around my throat, and I feel weak, tired, and just not well. I was shocked to find my thyroid levels were normal and in range. I've never had to take any meds for my thyroid. I do still get heart flutters and heart rate goes up sometimes. My endocrinologist said my thyroid produces too much hormone in spurts. I've only had thyroid storm one thyroid storm in the past. How can you shed some light on my situation as some advice? Well, first thing you need to do is a needle biopsy of that 3 centimeter mass to see if there is any cancerous involvement with the spread to the lymph node. I mean, that's the first thing to do. And there can be inflammatory thyroid conditions with spurts of overproduction. But if the thyroid has gotten big enough where it's pushing on your thyroid, it doesn't really matter. You may have to remove your thyroid regardless, even if there's no cancer in it, even if it's functioning normally. If it's pushing on the trachea and you're having breathing issues, that's one of the indications for doing thyroid surgery. So the first thing you need to do is biopsy the nodule around in your neck or on the left side under ultrasound guidance, so you can avoid the carotid, and potentially biopsy any of the nodules that look suspicious in the thyroid. All right, that's the first thing. Hopefully that helps. Sophie Milchevik. I'm in Australia, so I'll keep my questions short. I'm 36. I've been suffering for the past 3 years. It started with hyperthyroidism and Graves' disease, now advanced to hypercalcemia, hyperparathyroidism. I'm not on any sort of medications. My whole body aches. My leg bones squeak when I walk. You have a lot of pain. Now I feel my kidneys in trouble and constant aches on my right side. Could also be my lungs. I'm so out of breath at times, constantly have asthma. I'm waiting consultation for surgeon, and my endocrinologist wants the thyroid and parathyroid removed as quickly as they can find the troubled adenoma, he said, because I'm young. I've always had thyroid problems. I would love to hear your feedback, please. I would say one of the best ways to treat Graves' disease is obviously medications, and that's the first and primary thing to do. And your endocrinologist should put you on medications now. Even if you're considering surgery for it, put you on medications to decrease the over-functionality of the thyroid medication. And there's lots of good medications with very little side effects and good profile. So that would be the first choice, until you see the surgeon. And the surgeon's gonna do scans to see if they can find the enlarged parathyroid. And at that point, you can decide, Do I want to continue medication for the rest of my life for the Graves' disease or for an extended period of time? Or do I want to do surgery and remove the thyroid along with my parathyroid, since I'm having surgery in that area anyways? And those are options you can exercise and talk with your surgeon, right? But take the medications and start feeling better, right, in terms of the Graves' disease at least, before moving on, and that way you can isolate symptoms from Graves to symptoms from hyperparathyroidism. That way you can make a decision about doing parathyroid surgery and potentially thyroid surgery at the same time. Okay. Emina Alagic, hello and thank you for your time. I have a lump just above the Adam's apple to the left. And no imaging test discovered anything in the spot. I have thyroid cancer on the same site. Could it be ectopic parathyroid? If you're feeling a lump, then, I mean, it could be ectopic parathyroid, but you have to do blood tests to see if your parathyroid and calcium levels are elevated or abnormal or non-suppressive to know. But I mean, an ultrasound is probably the best way to assess that nodule, to see if there is something there, because it's right under the skin and ultrasound works really well. So I would suggest doing an ultrasound and also thyroid parathyroid labs. Ultrasound also is important for looking at the thyroid, since you have thyroid cancer, to see if the cancer, the shape and size of the cancer and the formation of the cancer looks similar to on ultrasound to that lump, or if that lump could be just a muscle that's tightened up, or it could be one of the bones and cartilages around your voice box. Okay, so those could be the possibilities. Anyways, that's the end of the questions. Hopefully I've been helpful. It's always a pleasure doing this thing. I always learn from you guys, and you guys just expand my mind and try to figure out more based on the questions you ask. I encourage you to follow your instincts. You guys who are here have educated yourself enough to know your hyperparathyroidism better than most doctors at this point. So to be your own best advocate. All right, best of luck, and I will see you guys next time around. Have a wonderful day.